I was particularly excited to think about this panel. As a clinician, I think that I have a lot to learn about how to translate stuff into policy and change and how to make that change disseminable. And I was just so excited that all of these wonderful people were able to come and be part of this panel. So Dr. Benjamin Sommers, a primary care doctor and associate professor at the Harvard School of Public Health, who thinks a lot about what is our safety net and how would we design it. And I was fortunate enough to take a class from him. He's just a really thoughtful person. I think he's going to be a great moderator. Kathy Sanders, who was my residency training director, more importantly, is the medical director and deputy commissioner for clinical services of the Department of Mental Health, and someone who is really leading the fight, the shared, passionate fight to close the mortality gap for people with serious mental illness. Next to her is Dr. Inga Lennes, who is a thoracic oncologist and a senior vice president of the Mass General Physicians Organization, who's really a champion of what is quality care, of the whole person, and how to make that work for people and for clinicians. And Senator Cindy Friedman is the chair of the Mental Health and Substance Use Committee, who I had the great fortune to talking to, was so open to this idea of coming together and really learning with us and thinking about how we can learn from her about how to influence policy. And finally, all the way from Dublin, Dr. Paul Dalton, who is a psychologist who's really done a lot of innovative work on mindfulness, who's the lead of a psycho-oncology service in Dublin. But in particular for this panel, he's actually helped to develop the National Cancer Strategy for Ireland and make sure that psychosocial care is an integral part of that and have it be implemented. So with that, I'll turn it over to Dr. Sommers.
Thank you so much, Kelly. So the basic format, we're going to hear some introductory comments for a few minutes on the shorter side from each of our great panelists, so then we can get into a give and take. And I may take the prerogative and ask a question or two, but for the most part, we're going to try to reserve a lot of time for questions from the audience and a chance for the panelists to respond to each other. So we're going to go in the order on the list here. So we'll start, Dr. Dalton, you're up to say hi and give us your opening comments.
Thank you. Can you hear me? Yeah. So thank you for the invitation. It's really lovely. It's really lovely to be here. I guess listening today and listening yesterday, I realized how different our worlds are. I come from a tiny island with about 6 million people on it, with a system that's quite tangible, a system that means we can get access to our policymakers, I think, a little bit more easily than you can do it here, by the sounds of it. It sounds really challenging. I guess my thought about looking at policy and the provision of care for people with cancer and pre-existing mental health difficulty, really the idea of it taking a village. It takes a village to raise a child. And in the same way, it takes a village of people like us, to begin to change a system to provide adequate and care that's equal for somebody who has a mental health difficulty and is diagnosed with cancer. It takes that village, and as one of our speakers this morning said, that village, in a way, needs to be guided by love and by discipline, probably in equal measure, or the idea that needs to be guided by compassion and competency. That compassion without competency maybe isn't worth as much. So over the last number of years, I maybe just to tell you a little bit about what I've done or what we've done in Ireland to as a village, as a tribe, to try and influence the nature of our cancer care services. I think in doing that, what's been very important is for the tribe leaders, for the leadership, to be very clear about the value that's guiding our advocacy. So what's the value base behind what we're doing? So why are we here right now? Without a coherent understanding of our value system that drives what we do as clinicians and policymakers and carers, we can suffer a kind of a drift, kind of a therapeutic drift. What's been very helpful for the group of people that I've worked with is for us to understand what we do from a human rights perspective. That frame provided a value-based form of advocacy that allowed us to see what was happening in terms of the very poor outcomes for people with pre-existing mental health difficulty as a violation of human rights. It's a language, a frame, and an orientation that I believe has appeal. Our former president of the Irish Republic and former UN Commissioner of Human Rights, Mary Robinson, once said that human rights are written on the human heart, long before policymakers proclaim them. So I think with that in mind, when we appeal through a human rights framework, we're appealing to something that's deeply embedded in the human heart. And when we do that, we have the capacity to change hearts and to change minds with love and with discipline, with compassion and competency. We, for the first time, have a national cancer strategy. So maybe I'll tell you briefly how it works. We have a different kind of health system that's similar to a national health system. What happens that every 10 years there's a cancer strategy, and a cancer strategy is basically like a menu that says this is what the cancer services need to look like in the country. This is where we want them to be in 10 years' time. So it's the menu. So there's a lot of work that goes into that cycle every 10 years, and there's lots of people like me and other people who advocate for certain things to be on the menu. So we've had 4 cancer strategies, so this is heading into our 5th cycle, and this is the first time our cancer strategy has had specific detailed recommendations about psychosocial care. So for the first time, statements of requirement that each of our cancer centres, there are 9 in total, have a fully functioning and multidisciplinary team with outreach into community, with adequately supported palliative care teams. So it's a huge achievement to have got it onto the menu. Our work now is to get it from the menu onto the table. And that's happening at the moment. And in order to so I guess there were 2 things that come to mind when I think about that. I think, well, how do we manage to do that? And we managed to do that because we adopted a three-legged stool approach. We had the professional community involved, we had the advocacy community involved, and we had the service users involved. And we presented to the people responsible for the cancer strategy a unified voice, a human unified voice that was good enough for the professionals involved, because it was the professionals who couldn't agree on a particular model of care. But we managed to identify a model of care that was good enough for the professionals. So the unified voice made it resulted in the recommendations being accepted. Our job now, as I say, is to implement. The journey towards that, just to reiterate, being based, being underpinned by our understanding of human rights and our failure to provide these services as a violation of human rights. So, thank you.
Great. Thank you very much. And we're going to move from the global stage to a more local stage and thinking about how institutions approach these issues. And we're going to hear from Dr. Lennes.
Hi. Great. It's wonderful to be here. I had the opportunity to be on this panel last year, one similar, and it's so gratifying to be back and to see all of the progress that's been made in this area over the past year, really thanks to Kelly and the team behind her that is working on this. So my role in the Cancer Center is as the Senior Vice President for Practice Improvement and the Patient Experience. I think of my world as our MGH community and even broader across the enterprise to the MGH hospitals. I happen to be a thoracic oncologist, and I see some of my colleagues in the room here. I think that in this arena, as we affect change across our local enterprise, I really think about how we change an organization like MGH. And what I've learned over the years is that this is not a command and control institution where we make a policy or a dictum and then we ask for it to be rolled out. What's better and more lasting, and something that works much better in this organization, is stakeholder engagement, shared accountability, great data that tells a story, and as Paul mentioned, the human side, the stories that change hearts and minds and get people to think about what should be next. And I think that's how I approach change in this arena. And I think that's how, when I try and talk to people about persuasion, I'm not a master at it, but that's the way that I try and approach it. I think the other sort of tenet that I always think about is there's a very famous quote from Brent James, who was the former head of the Intermountain Health and was sort of a quality giant there, and also works at the Harvard School of Public Health and other places. And he always is famous for saying something like, every system is perfectly designed to see the results that you see, something like that. So I really believe I'm being tough on the system, not on the people. The system, when we see results that we don't like, are often what I see time and time again is that the system is perfectly designed to get the inferior results that we see. So having a systems approach and thinking about how we design systems to get better outcomes, I think, is really important. I'll say a few specifics and then move on to get to the rest of the panel. As thinking about practice improvement in my job in administration, I'm very focused on access right now. Access is a national issue. I just came from the Patient Access Symposium, which includes all academic medical centers across the country, many of our colleagues and competitors. Outpatient access and inpatient access is critical crisis right now for patients. And I think about the segment of patients that we're focusing on today. Our usual methods of being able to allow access to clinical care are not appropriate, and they're not working. They're not working for our entire population, but specifically for people who have challenges around being available for phone calls or for other types of routine ways that we communicate with patients to arrange access. It's a disaster. Not only that, we don't have the ability to accommodate really detailed itineraries for care increasingly as the complexity of care gets harder and harder. So multiple appointments in one day, campuses that are spread out in many different places. We need new and innovative ways to be able to tackle these challenges. I think the second part of the job that I focus on in the hospital is the patient experience and service excellence. We're very concerned right now and very involved with how we measure service, and then making sure that we are feeding those service scores back to our clinicians at the front line, so that in the past, sometimes we measured the patient experience and nobody knew what those scores were or how patients were being affected. I will say that in this room, one of the places that we have to focus on even further is making sure that we're hearing the voice of all of our patients. And so the typical ways that we ask patients about the service that they've received are through phone calls, surveys, emails, and there's many different segments where that querying modality is not going to be the best for understanding their experience. So I fear that there's a silence, that we aren't capturing the experience of this important segment of patients. And that's a place that we have to improve on. The second part of that is our clinical structure in the outpatient setting. We've learned that great clinical structure to affect change includes navigators, includes multidisciplinary teams. It includes innovative communication strategies with patients, so texting technology for patients who enjoy texting or only text as a mode of communication, home visits, telehealth visits for those that have the technology. These are the things that I hope that, well, I know that you'll see in the future, and we need to be leading in these innovations to make sure that we break down sort of the silos and the old paradigms of how we deliver healthcare, which is not going to be anymore in a visit-to-visit scenario. It'll be much more based in digital communications and in communications that are multidisciplinary with several team members. So I'll stop there. Those are some of my thoughts and ideas and what we're working on at the local level. And I just wanted to say thank you for inviting me back.
Can you guys use the mics?
Oh, excuse me.
We'll make sure to
Let me
get
pass
through.
this way.
Let us know if you can't hear them.
Yeah, flag me down. I'll be watching. I'll make sure that everyone's on the mics. So we're going to next hear from Senator Friedman.
Thank you, and thank you for having me. I guess I bring the focus of what happens in the legislature and what we do to either hinder or enhance the delivery of services. As was mentioned, I am the Senate Chair of the Joint Committee on Mental Health and Substance Use Recovery, and I spend a lot of my time focusing on parity and on the parity between physical and mental health. And you all know it's the law in the land, and you all know that we are so far from achieving parity with regards to behavioral health that it's to me unconscionable and almost criminal. So I'm really focused on improving access to care and making sure that we have adequate networks and that the system is robust and that the silos break down, because we're still very much siloed in the way we look at presenting healthcare. You know, we talk a lot about for a long time, and it's still true, that the largest providers of mental health care in the Commonwealth and pretty much across the country are our courts and our jail systems. And you know, we talk a lot about how we get care to access to people with mental illness, and there's always a controversy about how far you want to go in pushing somebody into treatment, and there is a whole issue around civil rights. But I can't imagine anything more a violation of a civil right than to put somebody in prison because they're sick, and that's what we do. I think the Commonwealth is starting to look at this and look at it more seriously, but while I believe it's very clear and it's not medically right or morally right or heart right, we tend to look at things as a system in terms of money. And money is what drives so much of what we do at the state level, and so much of what we do in our you know, in how we set policy. And while people don't necessarily want that, and people are individually good, when you come down to it, where we start is how much does something cost? And then we figure out, okay, well, it's going to cost this much. What can we do? And so what I've learned and what I think it's really important and often uncomfortable is that we have to start to train people and teach people that providing really good care is not only the right thing to do, but it's the financially and economically right thing to do. If you're going to put somebody in jail for $57,000, which is the average stay, and that's not for somebody who actually has issues and needs more than just an average person, you can give people an awful lot of service for $57,000 a year. And so what we need to do as advocates and in the legislature is start to explain to people who don't understand the system at all that we're being penny-wise and pound-foolish. And right now I'm focusing on the enormous difficulty we all face in understanding what insurance providers do And what do they cover? How do they name things? I am a poor, person looking for care, and I can't navigate that system. You are providers providing care, and you can't navigate that system. And it's really set up in a way to do that. So what I feel like we need to really focus on right now in the legislature is getting that system to open its kimono, name everything the same so that we can understand it, have a conversation so that we can actually measure what is being provided. We are losing so many providers because they just can't deal with the system anymore. And that simply means that people aren't going to get care. So we're going to continue to struggle with this frustrating system. We're going to move as much as we can to provide patient-centered care versus insurance-centered care, and to move toward that parity that is not only the law but is the right thing to do. There are some hopeful signs. I mean, Mass Health is looking at a whole ACO model, accountable care model, of how you take care of the whole person. But we really need to understand what that means in terms of behavioral health, because we've never put those two things together, except in very limited circumstances with pilots that we've had and that we've sponsored through the legislature. But we really need to keep focused on what does that mean in an accountable care organization to provide that entire service, including people who have serious mental illness and serious physical requirements like a cancer. So I'll stop there and then.
And now from the city, from the public health perspective and mental health department, we hear from Dr. Sanders.
So it's great to be at the symposium again. Thank you very much, Dr. Irwin. What is really important that I think I really want to acknowledge today, because we are on a sort of a threshold. And that threshold is healthcare delivery reform. And it really is about how do we drive change to make our system of healthcare delivery much more coherent and something that is accessible and accountable and integrates behavioral health with the medical health. In other words, that's another way of saying the whole person. How do we make the person at the center? And the Department of Mental Health really is also right on pace with what's going on at here at the local state level, which is the island of Massachusetts, serving about 6 million population as well. And in our island, we are in this reform opportunity. And because Medicaid covers more than 25% of our population, changes in how we deliver care will drive the rest of the healthcare delivery system. That is our expectation, hope, and intent. And we're driving it based on behavioral health integration. My only regret about the plan was that instead of emphasizing and pouring the money into the community system and then letting it go from there, we're putting the money mostly in the hospital system and having it go from there. Somewhere along the line in this experiment or this initiative, we are going to come together and really deliver the right product at the right time for what's needed for that individual and their family. How DMH is involved is in this new accountable care organization system of delivery for Medicaid, which just started rolling out in March. The development at the Mass Health level of behavioral health community partners, which is designed to be a care coordination element between or among the people with severe mental illness and the accountable care organization managing a lot of the medical care. And a statistic I want you to be aware of is that federally, we're expected to have about 2% of our population meet the definition of severe mental illness. That's roughly about 150 or so thousand individuals. The Department of Mental Health, which is sort of given the command to care for the really severe mentally ill, we serve about 23,000, as you heard the commissioner say earlier today. That's a small component of who could qualify for that definition of severe mental illness. But it is really based on the most extreme need. And the Department of Mental Health is reorganizing its whole delivery of care around the individuals that are being supported to live as independently as possible in our communities with their severe mental illness, with an opportunity to integrate with employment, with education, with housing, with wraparound services that allow the individual to really function optimally. So that system of change, as well as the behavioral health community partners, are going online July 1st. And we're pretty excited about it. And this is sort of the policy panel and how we sort of make change through our regulations and how we can with our authority, our mental health authority. We have changed some of our regulations. It was sort of started by Governor Baker's initiative that all agency review all of their regulations to simplify and make them more useful. So over the last 2 years, we've been really reviewing a lot of that. We have now revised our inpatient hospital regulations that include an ability to make sure that the inpatient level of care in our communities meets the needs of the Commonwealth. And we've determined through our ED boarding studies and initiatives that the needs of the Commonwealth need to address those who have dual diagnosis with substance use disorders, dual diagnosis with developmental disability diagnoses, dual diagnosis with comorbidity with medical problems, and those who have behavioral acuity issues in their illness presentations. We also are regulating that our inpatient facilities do not reject anyone who meets commitment criteria. And in the spirit of that, we are actually promulgating sub-regulatory language about clinical competencies that all inpatient units have to rise to meet around those 4 special populations I just mentioned. And that is really game-changing. We're expecting inpatient units, whether they're freestanding or embedded in a general hospital, to have certain capabilities to serve those with comorbid medical conditions and others. So we're excited about that. That's going to be out there for reaction within the next week or so, with promulgation, with implementation by July 1st. So that's exciting. We also have redone our service authorization regulations, which will be going live July as well. And the big revolutionary aspect of it is that we're raising or reframing the age of who's an adult. Unlike other sister agencies, we have considered adulthood age 19. Now we are reframing it to be age 22. What this is going to allow us to do, even within our agency, is break down the silos between the adult and the child and adolescent systems of care. There's going to be much more coming together in that sort of 16 to 25 age, the transition age youth, so that we will be able to figure out what works. I know you've been hearing a lot of statistics about how things have changed over the years. I've just recently been aware of the fact that of those 22,000 individuals or so that we serve, in the year 2017, the median age was around 41. The mean age of death continues to be around 52, 53 years of age, and that has actually been level over the last several decades, even though the general citizen of our Commonwealth, their age of death has increased from the 70s to nearly 80 in that same 2-decade span. But what I wanted to mention is that median age of 41 for a Department of Mental Health client, but it's not a bell curve. Rather, what it looks like is a hat. It sort of like goes up around 16 and bumps up, and then around 21, 31, 20, around 28 years of age, another little bump, and again another little bump around 57. And then it plummets after age 65. That is very different than 10 years ago, and maybe different than 5 years ago, when it was much more of a bell-shaped curve. we are serving younger individuals. We are going upstream, we're excited, and we're into early detection, early intervention, really getting involved with people at risk before it turns into disorder, before it turns into chronicity, before it turns into a challenge for all of us in the community to support. We're excited about that. So these are initiatives that, as the Mental Health Authority, we are with our partners in state government and with our partners in the delivery of care throughout our Commonwealth and our educational system. We are partnering to go forward to meet the needs, to find the needs, and to meet the needs. And I have to just bring up another initiative that's very dear to the heart of DMH, and I think to all of you in the room and all of our healthcare delivery, but I'm going to say it. We have to also address the multi-diversity, racial, cultural, ethnicity that we serve, and that listening to the individual person, we have to hear the uniqueness that each of those areas of experience bring to what is challenging for that individual and what will help them be most useful, helpful, independent in their lifestyle. So that's what I really wanted to emphasize, and enjoy whatever else you as the audience want to have us address. So thank you very much, and let's get working together.
So I think we have some floating mics for questions from the audience, so if you do have a question, raise your hand, and our traveling microphones will come to you. And in the meantime, I'm going to toss out a question that really anyone here can answer, and also the audience members may chime in when you have your turn. So Dr. Lennes, you talked about the access crisis. And what I'm interested in hearing kind of from anyone on the panel is, there are so many potential bottlenecks, and what do you see as the areas that really are our highest priority? And this comes back to the senator's comment that ultimately, the cost becomes an issue. So where do you spend those resources? I mean, are these issues primarily about, visit wait times? Is this provider networks? Is this parity provisions in terms of what services are covered? Is this medical transportation? Is this primarily a mass health issue, private insurance? So big landscape, tons of places that we could have an access crisis coming from. What do you see as the key bottlenecks to try to address? And I'll open it to anybody who wants to jump in.
I could start and then. So yes, to begin with, I think but I do think I say that a bit tongue in cheek, but there are so many areas to address, and I think that any successful program is going to go after many of them. The ways that structurally we try to address some of these things are just going to some of the very most basic building blocks of patient access, and that is, when are we open? So we're open during times when a lot of people can't get here. So looking at different and alternative times for being open, late at night, on the weekends, alternative modes for delivery of care. Can we do telehealth visits? Can we do texting communication? Can we have teams that are built with not just MD providers, but with a variety of different roles and responsibilities? What are the different avenues for funding programs like that? Those are some of the building blocks. We call that capacity. I always tell people that access, at least to many of our services in the hospital, begins with addressing capacity. We can't have access unless we figure out what we have to offer, and making sure that we are structured, again, looking at the structure of the system to be able to provide access. And then looking at alternatives and being very creative about what access means. I do think that the levers for some of the incentives are not aligned where access is concerned, that many of the people on the panel already addressed. I think that also some of the ways that we are squeezed from payers in various different ways starts to, and the senator addressed this, starts to incentivize behavior that doesn't benefit certain populations. And so we have to be very mindful of that to make sure that we put in safeguards against that. So that may not be a totally satisfying answer, but I think that where I start is looking at capacity. We are very, very closely looking at our ambulatory world. Our ambulatory world is driving the hospital. So inpatient care is fixed. There's only so many beds and only so many rooms. Ambulatory care is less fixed, and there's a lot of opportunity for growth, and increasingly more complex patients are being managed in the ambulatory setting. So from a capacity and access standpoint, those are the places that we start. So I'll end there, and I'm sure there's others that have great comments as well.
Well, you know, just building, I want to build on your comment about capacity. And I do want to acknowledge that we have a workforce problem here. It's not just what we design and how wonderful the theory is, but we need more workers in the field. In the community healthcare delivery system, the turnover is immense. And that's a very important thing. I work overseeing some of the inpatient access from the emergency department. We may have licensed 2,500 beds for acute care for psychiatry in our Commonwealth, but sometimes that is effectively 2,000 beds because I am trying to help someone get into a bed, but the facility says our staffing does not allow us to go over this particular capacity, even though we are licensed for this much. Challenging. So part of that is, and I'm really grateful to what we're doing at Mass Health, because through the Accountable Care Organization initiative, we're using more than $1 billion of federal funds called DSRIP funds. And some of those are going into a mega loan forgiveness program for our healthcare workforce. And a certain amount of that is going to go to master's prepared behavioral health specialists of all kinds. And I am stunned when I review their applications for this loan forgiveness, the dedication, the commitment, the quality. But they are so poorly paid in the community system, and their debt is so high. It costs to go through education. And I'm just thrilled that we are having enough foresight to build in loan forgiveness programs. And I look to other ways of doing loan forgiveness for this workforce, including the agencies that hire them, the healthcare systems that provide this workforce as well.
So I'm going to jump to some audience questions with about 15 minutes left. Yeah, in the back.
Thank you so much. This was fabulous. I'm Eden Evans from Mass General, and I have a question for Dr. Sanders. It was really around access as well. I'd love for you to comment a bit more on raising the age of eligibility to 22 for adult services and how you see that expanding access for people with emerging serious mental illness. What will that mean?
So nothing in isolation. Everything has to be a complex and multi-pronged effort. So one of the things Massachusetts is a leader of, and you sort of heard Dr. Dixon allude to it earlier today, there is a federally funded and pushed effort around first episode psychosis. And we're right there at the table. It's one of our main commitments that we want to have evidence-based practices for any individual in this Commonwealth in their first episode of psychosis to get state-of-the-art evidence-based treatment. And to that end, we have developed a first episode psychosis technical assistance center. We have also developed that one of our research centers of excellence that we fund is going to focus on first episode psychosis. And we're applying for federal grants that will allow us to go even further upstream and work with high-risk population. So without getting more of those kind of services and programs available, we have to build it out. And building out those services is everything that we've been talking about in reference to collaborative care and integrated care. It's not just an office visit or a medication. It's family engagement, individual engagement, psychoeducational efforts, support to go back to work or education. You name it, it's all of that care coordination and care management. We have to build that out more. But we are looking forward to really making a dent on the face of mental illness by going upstream, by opening our doors to a younger age and finding what meets their needs and beginning to work with all of you to find ways and make it happen.
We've got a question right here.
So I just want to follow up on the access challenge. Dr. Sanders, you talked about the changes that were going into effect in July, and my question is for individuals in the community whom, by virtue of the psychiatric diagnosis, would not leave their homes to see providers. So how do we extend access to those people with the changes?
I'm hoping that people around that individual, because anyone can apply for another person's services at DMH. So family members can apply, hospital systems can apply. So there can be people around, and in the application process, we're opening up a more back and forth way to work out eligibility, or if not eligible, what services can be found for that individual. So I just encourage people to apply in that respect and make that barrier known so we can come up creatively to overcome it.
Dr. Dalton, is there anything on this topic of kind of reaching people who may not be easily able to leave their homes that you've seen in your strategies that have been effective?
I wish I could answer that positively and say yes. The answer is no, straight off. But again, I think coming back to one of the themes that have emerged today about engagement and community engagement, I think when we are reaching out to people in the community, very often we're relying on our community-based primary care teams, wonderful community-based nurses, who until now don't have anywhere to go with very serious concerns. So part of what we aim to do over the next decade are to support those people by innovation, through innovation with technology, so that we can reach out in a way that's much more effective.
So I think this is a really important point, especially at this juncture, because I think we suffer from the same problem here. And while you can become a DMH client, which is I think what you were referring to, it's very, very difficult to do. And it's for people of a certain kind of profile. The problem is that I think is that as long as we have a system where we expect people to come to us, and those people have, by the very nature of their illness, an inability to do that, we are never going to break that. We're never going to bridge that gap. And so until we start paying for a model that pushes people, providers, out into the community and compensates them and acknowledges that their jobs are not about sitting in an office waiting for somebody who does not have the ability to do that to show up. And that's the model we use, and that's how we pay people. And until we get very, very, very active, outwardly active, transparent, clear, that this is the kind of model that we're looking for, we're not going to address what you're talking about. So much of the job that the people who serve people with mental health need to do is follow up, is check in, is helping them get to their cancer care, because they're incapable of doing that, of not waiting for them to tell you what they need, but to be there so that you can see what they need. And that's what we've got to make sure that our system, and we have a good opportunity, as the doctor said, because we are changing over into how we look at the delivery of care. But we still carve out mental illness. We still carve out mental health. Mass health carves out the way they serve mental illness. That in itself could be ripe for a problem. So we need to be sure, and you need to be there to say, this is not working. And we need to hear from you so that we can go in and advocate and say, I know this is what's on paper, but what's happening in the streets is not what's happening. And I think that's what we've got to kind of push toward. It's not cheap, but it's much more efficient, it's much better care, and in the end, everybody is better off, including the state. So.
Question up here.
Couple things. So we have a new model that Dr. Sanders said. By the way, hi, Senator Freedman. Haven't seen you in a while. So we're rolling out the new model in July, and you and I discussed, from my point of view as somebody who worked for the state for 30 years, now as somebody who works for a community vendor, the model has multiple problems with it, that it has a workforce problem, and it calls for a number of licensed clinicians across the state at an incredible rate with lousy pay. And I always wondered, having come from the state to work for a vendor, why I just retired from state service, and I now work full-time for a vendor. I worked for state service for 30 years. I'm going to be very honest with people here. My pension is greater than what I'm now earning as a full-time employee of the vendor agency, doing relatively the same work, although I did inpatient before, which is a life of its own. And so I don't see how you can expect people to be doing the kind of work that needs to be done with a master's degree, with experience, to walk into a job and say to that person, we're going to pay you $50,000, $55,000 a year. It's never going to work as long as people want to do it on the cheap. It is not ever going to work. It looks very nice on paper. It's very nice theoretically. But we're talking about the difference between what we see as theory and on paper and what we see on the ground.
Great. Any reactions from the panel?
This is going to fail because it has a workforce development problem and it pays people buckets for very, very difficult work. So,
Anyone want to jump in on that?
And if we actually had a model, like Senator Friedman was talking about, if people, that's what we decided to do. We're just like, whatever, we're just gonna do whatever we want. And I have the luxury of doing that at an academic hospital with a little bit of free time. But really, no one allocated salary effort to that. I just said, I'm sick of it. I'm sick of wasting my time doing stuff that's not working. And I'm gonna spend my time doing stuff that's effective, and then I'm gonna do it enough, work hard enough to get faster, and we'll be like, okay, we'll pay a little, and then we'll do more. That's just one way to make change, but I just wanted to say that I think it's really important, two things. One, that the clinicians who are in the field, who are doing much tougher work on the ground than I am, have a direct line to me. You know how people say they text me, they page me when they're worried, and I help them. And not just me, but a system of people who have the clinical expertise and access to care that can make things happen fast for them when they need it. Because people shouldn't worry alone, right, Kathy?
Right.
That was the mantra of our residency. But we also need leadership on the policy side who's going to acknowledge the fact that it's one step to say behavioral health community partners, it's another step to actually say we're going to allocate the clinical care and flexibility to do it right. I mean, and I hate to say this, I think it's wonderful to have care coordination. You have to have care first. You have to have clinicians delivering the care first. And you have to give people the flexibility to do it right. And then we can train them how to do it. We know how to do it. That's not the issue. We have effective strategies. It's just people are paid to do us out of the box, and when you're not paid to do it, and you have a team telling you to do it, it's really hard to do that on your own.
Yes, a question over here.
I just wanted to continue the conversation that Kelly, to make the same point, and actually to ask Dr. Sanders whether the state has any more short-term plans to have more of a workforce of clinicians. I mean, it's wonderful that we have so many navigators now and other clinicians that can work, not clinicians, other providers that can support patients in getting to places, but we need to have people in those places. And also we need, as people mentioned, to have livable salaries and to provide the kind of supervision and support to clinicians that they need to survive. It's not even to flourish. And I just would like to hear from you if there is something more short-term. I know the community partners, that's coordination again. So that's not going to take care of the clinician piece of it. And in the community, as you probably know very well, when we call to schedule a patient, it's 3-4 months, and that's not acceptable. And sometimes it's just to see a therapist, not even to see the psychiatrist, because it's even longer for that.
So thank you for that question, but it really has so many other questions embedded in it. But what I do want to acknowledge is that Senator Friedman, really, you have expressed something that's very crucial, which is that we have to develop the model. I didn't go into any details about the adult community clinical services, which is the new DMH model of care around the population that's the most severe ill, living as independently as possible in the community. That system of care is a model of care. I know we don't have all of our fans of it, but it is built on a more clinically driven monitoring, oversight system, almost similar to what you said, Dr. Irwin, that it's developed so that 24/7 there is a clinician supervisor that can answer questions, that can guide or direct, so that no one is on the front lines, more or less, alone. That in itself is great kind of efforts to support the workforce in the field, that ability to call, that ability to have oversight and monitoring. And DMH is going to be much more involved in its oversight and monitoring of this new program that we were just funded completely for. And I'm just going to take a little commercial aside and say thank you, Senator Freedman. The Senate passed the budget. We just heard about it today. DMH is getting a 12 to 13% increase in its budget that no one in living history has seen ever for the agency, and this new program is fully funded. So we're very excited about it. To get the workforce, it's crucial, but that is what we're going to evolve, and we're layering, and we're integrating, and we're going to go forward with this model.
Maybe I'm going to ask one last quick question, I think, then we're going to wrap things up. Senator, we have an elected official sitting here at the table. I imagine all of us at some point, if today, if not every day, watch TV or read the newspaper and say, how do I influence what's going on with our elected officials? How do I communicate better? How do I broaden this, broaden our reach and get strategies into effect? So what advice do you have for us as stakeholders, patients, doctors, clinicians, and others?
Get really loud and get really cranky and keep it up. Seriously, we just passed a big criminal justice reform bill in Massachusetts, long time coming, had some very, very important changes to make our criminal justice system a fairer and more just enterprise. What it took to do that was people inside the building that really, really cared about this issue, and an enormous cohort of advocates outside the building, and who really pushed for change. And they weren't people who always come together, right? They were faith-based services, police, the people who had come out of prison, people who had people in prison, people who were doctors and saw the health issues around the way we deal with our criminal justice system. It was a real cohort and a group many groups that came together, and through their pushing, their advocacy and not letting up, and having some real champions inside the legislature, moved this forward. You have enormous power in your hands. The healthcare system is the #1 employer in Massachusetts. If you can get the right coalition of people together and thinking outside the box of who they are, you can make a huge difference. So it's finding your allies inside, and it's building your coalition outside, and it's not giving up. That's really how simple it is, because actually elected officials pay attention to the voters. And if you don't show up, you don't get a voice. And if you show up and you bring a lot of your friends and you don't back down, we listen. And it really is as straightforward as that. And it's fighting against the big, powerful interests that don't want to change. But with enough people behind us, and enough advocacy, we can make that change. So that's the sort of 3 key pieces to it. Thank you.
This was a wonderful, wonderful way to end Friday. I know a lot of you will be back on Saturday to learn more about partnership. And if you're by chance not, please do fill out your evaluation. It would really help us make the collaborative meet your needs better. You know, Paul also was involved in a wonderful campaign called Changing Hearts and Minds, where actually in Ireland, classic Ireland, really Catholic, not super accepting of being gay and lesbian traditionally, and they passed gay marriage. How did they do that? I think this is a really important story for me. It's how I learned a little bit about being an advocate. And they did that by telling stories. And they did that by having someone call their grandmother. They did that by saying, my neighbor. They did that by saying, of course, well, maybe I don't think about that, but of course, grandson, I'd love you to get married. Of course, I would never want you to be deprived of the human right of marriage. I would urge us all in this room that we need to do the same thing about mental health. We need to say that this isn't someone over there, this is my friend, this is my neighbor, this is my grandson. And I think that piece of it, in addition to the data and the advocacy and the knowing people, is critically important. And I hope that's part of what we can do together as a coalition. And I just wanted to thank you all for being here.